From where do I? A very good morning to all of you. I would like to thank Dr. Vitull Gupta for having me here. And I would also like to tell him that I think this audience is really very good because all the people that I have are the best, and they are the people who would actually give their inputs and probably put into practice into their areas for the betterment of the field that we were just now talking about. And that field is nothing less than what is very dear to my heart, and that is cardiovascular diseases in women. An acute coronary syndrome in women, how to approach and manage is the topic given to me for the day. So ladies and gentlemen, we all know that cardiovascular diseases are now the #1 cause of mortality in women. And the mortality is much more than all the cancers put together. We put so much of hue and cry to breast cancer, cervical cancer, endometrial cancer, but all the cancers put together versus cardiovascular disease at every age causes more deaths in women than all the cancers put together. Having said that, I would just take you across a few cases. So this was a 35 years old female, a diabetic, who presented with anterior wall MI and ejection fraction of 38 to 40%. She was thrombolized with tenecteplase. So this was her ECG showing anterior wall MI, was taken to the lab, and we saw this was the LAD, and in LAD there was a lot of thrombotic burden which was present. So I was just passing by in the cath lab. This was my colleague's patient, and he called me. She said, see, this is a 35 years old female patient who has come with MI, and you see what needs to be done. So anyways, she was kept on intensive antithrombotic pharmacological regimen, and a check angio was done after that, which revealed a recanalized left anterior descending artery, and this patient was left on medical therapy. So I went to the patient and I started talking to her. So for no risk factors, however, when the history was revealed, it revealed that this patient had history of gestational diabetes, multiple abortions, and intrauterine deaths, which was there around 15 years back when she was pregnant and she had gestational diabetes and then recurrent abortions. So ladies and gentlemen, it's important for us to understand and know that causes as gestational diabetes and pregnancy-induced features can be having a bearing for cardiovascular ailments in women. Now another case, 29 years old female. She comes to us with anterior wall MI, and she's taken up to the cath lab for a primary angioplasty. Her LAD totally occluded, the lesion wired, the lesion stented. The stent is placed in her left anterior descending artery. Mind you, it's a 29 years old female. This is the last thing that we expect a 29 years old female to come to us with a massive MI. So a primary angioplasty was done. She was started on antiplatelets and sent back home. Now 7 months back she comes to us, and now she comes to us with pregnancy. And she is 16 plus 4 weeks pregnant. So a 29 years old lady who is post-angioplasty on statins, beta blockers, ACE inhibitors, PPIs, now presenting to us with pregnancy. So this is the scenario that we have, which is gender-based and different than men. Had to talk to her. The family ultimately opted for MTP, given that all these drugs the patient had received, suction and evacuation was done on antiplatelets. Antiplatelets could not be stopped because the recent stent was placed, and she had history of menorrhagia post. However, she was managed. So the latest dictum is that in patients who are receiving anti-revascularization, the women pregnancy testing should be a routine when we are evaluating. That doesn't mean that we don't shift them to the lab. However, we should have a pregnancy test done in them, and they should be encouraged not to get pregnant. And of course, ones who conceive, a multidisciplinary care is needed because antiplatelets cannot be stopped in these patients. Yet another patient, this time it's a 68 years old lady who comes to us with acute inferior wall MI. So her RCA was completely occluded. She was again wheeled into the cath lab, the lesion wired, the lesions stented. We can appreciate the massive slow flow which occurred immediately post-stent. So there was no flow in the artery once the stent was placed. We had to give a lot of vasodilators, give intracoronary epinephrine, do suction of the thrombus. We had to struggle for a lot of time because the patient's hemodynamics, the slide is not moving. Because the patient's so the patient's hemodynamics collapsed. A lot of suction and evacuation had to be. No, it's previous one.
This one?
No, previous one.
Sorry.
Yeah, this one. So sorry for the technical glitch. We can see that there was a lot of thrombus and the thrombus suction had to be done. The patient collapsed, the hemodynamics were not improving, took us a lot of time. And ultimately, with great efforts, we could restore flow. However, the patient had to be placed on an intra-aortic balloon pump. And this was the final TIMI-2B flow only which we could get in her vessel. So this was a 68 years old female, this time 62 years old female who presents to us with anterior wall MI. Again, we can appreciate the left anterior descending artery, which was totally occluded. The lesion was wired and a stent was placed. This patient also in the cath lab collapsed. There was slow flow. Intracoronary suction was done. Despite intracoronary thrombus aspiration and administration of all the possible vasodilators, you can see here the flow in the LAD was still not restored. The patient was put on an intra-aortic balloon pump. Ultimately, we were able to manage some TB2B flow in the 62 years old female, and the patient had to be shifted back to the EMR on IABP with TIMI-2B flow. However, this patient succumbed the next day to her no flow and could not make it. She had persistent VT storm. So that was a 68 years old inferior wall MI with no flow. Last was 62 years old anterior wall MI with no flow on IABP. Now this is a 64 years old female who wheels into the emergency with this massive inferior wall MI. We can see the sinus bradyarrhythmia. The blood pressures are unrecordable. Fluid resuscitation is done. Loading dose is given. She's wheeled into the cath lab for a high-risk primary PCI. And as expected, we identify a right coronary artery which was 100% occluded. So the lesion was wired. The stent was placed. However, despite the placement of the stent, the flow in the arteries was very poor, and the patient succumbed. Another stent had to be placed. The slides are not moving. However, this patient, so this was the final flow that we could get in the coronary artery, and we can see the right coronary artery has only TIMI-2B flow, a very slow flow. The patient's ABG was done. She had persistent hypotension. She was started on very high dose of inotropes, persistent metabolic acidosis, high lactate levels. The patient was electively intubated and hereby taken up for a VA ECMO. The patient remained on ECMO. She faced a lot of issues like local site issues, oozing, anemia, sepsis. Ultimately, on day 3, we could wean off her ECMO. So ladies and gentlemen, we just now saw a series of female patients, a 29 years old lady who comes with primary angioplasty and becomes pregnant. A 35 years old lady who had previous history of gestational diabetes comes to us with MI. And now the 62, 64, and 68 years old lady, all of us who come to us in a serious hemodynamic catastrophe and present with myocardial infarctions. So women are different. Their presentations are different. Their risk factors are different. So we can see over here that when women come, they have some female-specific cardiovascular risk factors, some female predominant cardiovascular disease risk factors, some female-specific cardiovascular diseases, and female predominant cardiovascular diseases. If we talk of female-specific cardiovascular disease risk factors, they are adverse pregnancy outcomes, pregnancy-related hypertension, preeclampsia, eclampsia, gestational diabetes, preterm delivery, polycystic ovarian syndrome, reproductive hormones. So all these are female-specific risk factors. In fact, the latest European guidelines on hypertension have now placed these sex-specific risk factors as disease modifiers to be included while planning the management of hypertension. So they're becoming all the more important now that we realize that these factors have a bearing on cardiovascular status of a woman. Then there are some cardiovascular predominant risk factors which occur in men as well as women, however predominantly in women, and we all know there are autoimmune diseases like rheumatoid arthritis, SLE, scleroderma, the breast cancer and breast cancer related treatments, which can cause fibrosis, the chemotherapeutic drugs, and then female-specific cardiovascular conditions like peripartum cardiomyopathy, which would occur only in women, and female predominant cardiovascular risk conditions as MINOCA, NOCAD, Takotsubo cardiomyopathy, endothelial dysfunction, microvascular dysfunction, heart failure with preserved ejection fraction, spontaneous coronary artery dissection, coronary vasospasm, and so on. Having said that, the very recent AIIMS statement actually identifies that it's not just traditional risk factors or pregnancy-related risk factors or risk factors associated with reproduction like early menarche, premature menopause, hormone-based contraception, or other disorders. Some things like social determinants of health, cultural issues, cultural norms, language, and health literacy, especially in this part of the world where we are living, has a bearing on cardiovascular diseases in women. And let's see what are these social determinants: a low education, a high psychological stress, access to care, environmental barriers, linguistic barriers, low income, health illiteracy, discrimination, unconscious bias, and lack of social community and resources. And we would agree that they occur right in front of us when women come to us with medical ailments. So ladies and gentlemen, ischemic heart disease, when it occurs in women, in 50% of cases, these patients may not actually present to us with chest pain. Their symptoms would usually be atypical. She would complain of breathlessness, some jaw discomfort, some headache, some just tightness, and these symptoms could be CVD mimics. Patients can present with heart failure, cardiogenic shock, restenosis, and complications much more as compared to men when women have coronary artery disease. Women have a higher prevalence of plaque erosions. The ruptures of plaque is less in women. And if we look at plaque morphology in a woman when she has a coronary syndrome, it's less of calcium, less focal obstruction, more diffuse atherosclerosis as compared to men, and more of outward remodeling of the coronary arteries. Microvascular dysfunction, we all know, is much more reported in women who might have normal coronary arteries even when they have MI, and their coronary blood flows at rest are higher and they have lower coronary flow reserves. So understanding sex differences in acute as well as chronic syndromes is very important. In acute coronary syndromes, we just now mentioned that the plaque volume is lesser. There is more plaque erosion and less plaque ruptures, which are seen in women. However, in high-risk lesions, the thin cap fibroatheroma, which is there, is prevalent, equivalent in men as well as women. So this is how it looks like. This cartoon shows us that if we look at the coronary artery, a woman's coronary artery is small. It is smaller in size as compared to a male's coronary artery, which would be larger. The reference diameter would be more. And if we look at the area of myocardium that is subtended, a woman's coronary artery would subtend a lesser area of myocardium as compared to a man's coronary artery. So hereby the implication is that if we talk of FFRs, the fractional flow reserves, which are used to determine whether we need to revascularize an artery or not, are comparatively much higher in case of women. So sex-related differences in FFR are important, especially in intermediate stenosis, and women have more favorable outcome when we are able to do FFRs in them. And if we look at women, what about rehabilitation? They utilize the cardiac resources less common. The first medical contact to the device time is longer for women. They are less referred for revascularization. They less receive the cardiac rehabilitation. And this is what happens if we look at their symptoms. And, you know, there's an age-based difference. A younger woman who would come most likely with chest pain. An elderly woman who would have more of atypical symptoms like weakness, breathlessness. If we look at when they seek care, a younger woman would seek care, but the physician would probably ignore it, saying that, oh, it could be a functional case. An elderly woman would seek care late. She would try to ignore her symptoms. Pregnancy-related risk factors, more common in younger patients. Traditional risk factors, more common in elderly patients. Then, if we look at what was happening to coronary arteries, catheter-induced dissections and spasms are found in younger patients when they come for PCIs, and elderly patients usually tend to present with Takasubos or Minoka. Disease modifiers as frailty have adverse outcome in elderly women as compared to depression in younger women. So women present late, a STEMI protocol has been developed so that they come earlier, atypical presentation, more comorbidities, assessment bias by the physician, biological bias due to reproductive factors, and treatment bias leads to adverse outcomes. This was the study we did at our center of around 35,000 patients, and we found that over a period of 15 years, just around less than 30% women come for health checkup, and most of them are post-menopausal. So there are a lot of knowledge gaps in the field as regards plaque pathology, revascularization strategies, microvascular dysfunctions are there, and this cartoon beautifully shows how women are different when we talk of coronary artery disease. They have 1% stent thrombosis with latest stents, 4% more severe bleedings as compared to men, 8% in hospital mortality, 20% of women are SAD, 22% of young women have plaque rupture, 30% will have concomitant diabetes, 40% have SCAD, 40% severe bleedings, 50% higher prevalence of depression, more than 50% have a higher in-hospital mortality, 70% of these patients have non-obstructive CAD, no obstruction, and 90% of them would have Takasubo cardiomyopathies. So women in comparison to men have a childbearing potential. They have smaller arteries. They are too old at times to be, and they're underrepresented in the randomized trial. However, they derive the same benefit from all the procedures and should be given the benefit of that. Female disadvantage in CVD belongs not just to the female herself, it also belongs to the professional where the physician ignores, and there are so many risk factors that we need to be aware of. These slides are very dear. Before I end, I would like to say that cardiology for women is not a religion for cardiofeminists, but it is an evolving scientific field with evidence-based data that needs to be implemented in clinical practice. A culture shift is needed in cardiology. God created men and women equal, and he created them different. Different doesn't mean inferior or superior to the other. It simply means different. And these differences between men and women are necessary because of their God-given purposes. Thank you very much.
Thank you very much, Dr. Shibba. Excellent talk. I think your talk is going to make people aware that we should have different opinion, clinical features, as well as treatment protocols for men and women. So now it is not the era for one fit all. So we have to look for gender bias or gender things in our clinical practice. Thank you very much. Now the session is open for discussion or any comments.
Could be, yes. So this patient was not on my follow-up, but yes, was advised to get APLA. Why not? So multiple abortions, but then she had gestational diabetes also. So this was just to acclimatize that these factors occur. So thoroughly agreed. In fact, pregnancy test is now, there have been articles which say that pregnancy is a stress test for women. So how she undergoes that pregnancy actually, forecomes, it's a harbinger of her future cardiovascular health. It could be APLA, but then I don't think she had any other associated features, and I think it was done, though by my colleague. Yeah.
Excellent talk, Dr. Shibba. If you remember the CREATE registry data, which you published in the Lancet long back in 2008, that also clearly stated that women have atypical symptoms, they present late, and very importantly, they have a poorer outcome because they receive less evidence-based treatment, less interventions, because the family doesn't want to spend on women.
Yes.
So that kind of bias was also documented long back in 2008 in our CREATE registry data, which was published in the Lancet.
Yes,
and you have brought it out very nicely. Thank you very much.
Thank you very much for that comment, sir. In fact, now that you've said that, I remember that Dr. Rajiv and myself, we had also published a data, and that was on National Rural Health Mission that we used to have. So free surgeries were being done for female as well as males. And in our center, we realized that 1.66 was the ratio of male children who were receiving treatment as compared to females, even when the treatment was thoroughly free of cost. So issues of scar in a female child, issues of why spend on a female child, like you said, that a family is never having that inclination. So we had in fact published it in Heart Asia.
So I got to remember my days in PHC in way back in 1991. One patient of severe mitral stenosis came, and when I told them in PGI, at that time it was costing about 20,000 rupees to her husband, and her husband said to me on the face in front of the female that I can buy 2 more wives in 20,000.
My God.
I will not get this thing. That is imprinted still in my mind,
yes,
that gender bias, socio-economic issues are really, really important in our society.
Yes,
Thank
sir.
you very
Thank
much
you very
for
much.
bringing it out.
Thank you,
Thank
sir.
you.
Thank you.
Thank you, ma'am, for this insightful presentation.